Hello everyone and welcome to the last installment of Derm School. Today we will be looking at skin cancers. We will be covering the three common types of skin cancer: basal cell carcinoma or BCC, squamous cell carcinoma or SCC, as well as melanoma. First, BCC. BCC is not only the most common skin cancer, it is actually the most common cancer. It's caused by UV radiation as well as a PASH gene mutation. Clinically, there are many different types, but overall, BCCs are locally invasive, aggressive, and destructive, but they are slow growing with limited tendency to metastasize. These are the risk factors of BCC: episodes of severe childhood sunburn, red hair, tan poorly, North European ancestry, family history, immunosuppression, exposure to arsenic, previous radiotherapy, and other genetic conditions such as albinism, xeroderma pigmentosum, or Gorlin syndrome, also known as nevoid BCC syndrome. This is the most common type of BCC, the nodular BCC, and it is typically solid. It is commonly found on the face and presents as translucent pearly nodules, which slowly enlarge. These are shiny and well-defined, as you can see in the picture. And there's the presence of dilated superficial capillaries. When diameter is more than 5 mm, it can ulcerate to form a rodent ulcer, and there's often a pearly rolled appearance at the periphery. Nodular BCCs or whatever type can also be pigmented. So these are pigmented BCCs, and they are commonly found in the Asian population, and it can range from brown to red to black. Other subtypes of BCCs: micronodular. So these resemble nodular clinically but differ histologically and are of higher risk. Superficial. These are commonly on the trunk and presents as a thin plaque with a thread-like raised edge and central atrophy or scaling. Sometimes, especially in the Western population, we can find superficial BCC coexisting with a nodular BCC, usually at the edges. Adenocystic BCC. This is a diffuse plaque with broad edge and cystic components which make it translucent. Morphic or sclerosic BCC. This is rarer, usually on the face, and presents as an indurated scar-like waxy yellow plaque with ill-defined margins. An infiltrative BCC is clinically similar to a morphic variant with indistinct borders, and it is not embedded in a dense fibrous stroma. So the more higher risk types of BCCs are micronodular, morphic, and infiltrative. This is a picture of a morphic BCC. This is a superficial BCC. You can see that it's a thin plaque on the body. BCCs are most commonly found on the face, more than 90% of cases. Danger sites are the medial and lateral canthi, nasolabial fold, and postauricular areas. On the trunk, you find superficial multicentric BCCs. In terms of approach, if you suspect a BCC, you can excise it with 3 to 4 mm margins. If planning for Mohs surgery, you should do a shave biopsy. We will prefer you not to do a deep punch biopsy as the scarring can obscure our histopathological findings. You can also consider cauterization and curettage for selected lesions. These are the management of BCC: surgical excision, Mohs micrographic surgery for those higher risk types of BCCs on certain areas, saucerization and curettage, cryosurgery, radiotherapy, topical 5-fluorouracil or imiquimod for superficial BCCs, photodynamic therapy, and Hitchcock pathway inhibitors for metastatic or advanced disease, such as vismodegib or sonidegib, or immunotherapy with samipilimab. If you have certain types of high-risk skin cancers, Your doctor may recommend Mohs micrographic surgery. It is a highly specialized and accurate type of skin cancer surgery in which the cancer is removed layer by layer until we are sure that there are no skin cancer cells left, and this is known as clear margins. Besides having high accuracy and a very good high cure rate, we also aim to remove the least amount of tissue in order to preserve certain areas of skin. First, we mark up the area of skin cancer that we can see, and then we numb the area with local anesthesia. The tumor that is visible is then cut away or scraped off. We then remove the tumor and a small rim of skin around it. This is known as a layer. We then use ink to dye certain parts of the layer so that we know which way it was sitting on your skin. The nurse will then place a secure dressing over your wound and you will be allowed to sit in the waiting area. So this period will take about 2 hours when we actually take the tissue to the lab to be processed and analyzed. Now during these 2 hours, you will be allowed to rest, eat or drink in the waiting area. Now the layer that we took will then be sent to the lab. It will be frozen into a block and sliced into small, thin sections so that we can see what the tissue looks like. Now, if after analyzing we find that there are still cancer cells left, we will need to repeat the process. So we do this until there are no more cancer cells left. Please expect maybe 2 or 3 goes on average. Most times, there will be stitches placed to bring the wound edges together, alright? Or you may require what is called a skin flap or a skin graft. So for a skin flap, we will move adjacent tissue from around the area of the wound and stretch it or move it over to stitch into the wound. For a skin graft, skin will be detached from another area and removed and stitched over your wound. Sometimes we will require the aid of other teams such as the plastic surgeons or the eye surgeons to help to reconstruct your wound. After the reconstruction, a dressing will be placed over the wound and instructions will be given before you leave. To know more, check out the information on the website where there's actually a patient information leaflet that you can refer to. Our next topic is SCC, squamous cell carcinoma. Squamous cell carcinoma is a malignant tumor of keratinocytes arising in the epidermis. It is the second most common skin cancer in whites and accounts for 20% of all non-melanoma skin cancers. It commonly affects the elderly men on sun-exposed sites, especially on the head and neck. These are the risk factors for SCC. Recent or cumulative UV radiation, fair skin with red or blonde hair, history of severe sunburn, sunbed use, 200 plus treatments of PUVA, which is phototherapy with ultraviolet A and Soralen, smoking, chronic immunosuppression, previous exposure to polycyclic hydrocarbons or radiation, exposure to arsenic, human papillomavirus, genetic mutations in P53 mutations, xeroderma pigmentosum, and albinism, the presence of actinic keratosis or in situ SCC, as well as sites of chronic injury such as scars, ulcers, and infection. Invasive SCCs arise in areas of pre-existing actinic keratosis. They present as ill-defined, firm indurated nodules, plaques, which can be verrucous or ulcerate. These are often yellow-red and enlarged with surrounding inflammation. This is a picture of a highly differentiated invasive SCC. You can see the presence of keratinization within or on the surface of the tumor, and it is often firm or hard. Comparatively, the poorly differentiated SCCs, there are no signs of keratinization. It is fleshy and granulomatous and soft upon palpation. This is a keratoacanthoma. It is a rapidly growing, self-resolving hyperkeratotic nodule. In some places, it is regarded as a form of SCC and should be treated as such. Precursors of SCCs include actinic keratosis, in situ SCC or Bowen disease, cutaneous horns, as you can see on the picture on the right, as well as chronic inflammation or scars. This is a picture of in situ SCC or Bowen's disease. It's a scaly and erythematous plaque. Metastatic risk for SCCs, it's higher in patients with scars, chronic inflammations, lip, ear, and non-sun exposed sites. These are the common sites of SCCs: patients with a bald scalp, cheeks, nose, lower lips, ears, preauricular area, dorsal of hands, forearms, trunk, shins on female, genitalia, lower limbs, and face. An approach to SCC: excise with 4 mm margins if less than 2 cm in size and probably well differentiated or keratoacanthoma. Otherwise, use a margin of 6 mm. If planning for Mohs surgery, do an incisional biopsy or, less ideally, a punch biopsy first. For a low-risk lesion, you can consider cauterization and curettage. Staging of SCCs: always remember to examine the lymph nodes in patients with SCC. Imaging indications are for nodal metastasis for high-risk tumors, namely Brigham and Women's Hospital category T2B and above, or patients where you suspect deep structural involvement where there's extensive localized disease. Examples of imaging: CT scans, PET-CT scans, or ultrasound. Management of SCCs. So firstly, surgical excision. In patients with high risk or recurrent disease, you can consider Mohs micrographic surgery. We've discussed that in detail. Saucerization and curettage for small, well-differentiated primary SCCs. Radiotherapy. Regional lymph node dissection might be needed for metastatic lymph node disease, and for advanced recurrent or metastatic disease, you can use immunotherapy with semipilimab or pembrolizumab. And lastly, melanoma. Melanoma is the most malignant tumor of the skin, and of all the three entities, this is the most dangerous and most life-threatening. So this arises from malignant transformation of melanocytes at the dermal-epidermal junction, or from nevomelanocytes of dysplastic nevus or congenital nevomelanocytic nevus that become invasive and metastasize. These are the risk factors for melanoma: genetic markers such as CDKN2A, BRAF, and MC1R, fair skin, family history of dysplastic nevi or melanoma, personal history of melanoma, ultraviolet irradiation, especially sunburn during childhood or intermittent burning exposures, patients with more than 50 or more than 5 mm melanocytic nevi, congenital nevi, more than 5 dysplastic nevi, and dysplastic melanocytic nevus syndrome. This is the ABCDEF rule for melanoma: asymmetry, border, which is irregular, color, which is not uniform or multiple, diameter more than 6 mm or ugly duckling sign, which means that it looks different from all the other nevi that you have, elevation or evolving, as well as funny mole. This is nodular melanoma. It is often found on the trunk. It is a raised black or blue nodular growth and may ulcerate. This is lentigo malignant melanoma. It occurs in sun-exposed areas, affecting older individuals, especially on the head and neck. It arises from pre-invasive lentigo maligna, and there's a densely pigmented nodule within an original macular lesion. This is superficial spreading melanoma. Common sites are calves on women and backs on men. There's an asymmetrical, irregular outline. It may be crusted. There are different shades of brown, black, red, blue, or white. It expands radially and vertically. This is a dangerous condition. It is amelanotic melanoma, and you can see that there is much less pigmentation compared to the other types, and therefore it can be a difficulty in diagnosing this condition. It often presents as a rapidly growing nodule. There may be some brown pigmentation as well as the presence of telangiectasia. Acrolentiginous melanoma is more common in Blacks, Southeast Asia, and India. There are a few types. For plantar melanoma, it is often found on the soles. There's firstly a macule which enlarges to form a black elevated nodular component. For a subungual malignant melanoma, there's black pigmentation beneath the nail plate. often lending to Hutchinson's sign, which means pigmentation of the nail fold and is characteristic of melanoma. So this is a picture from a case series that represented in the MJD. So you can see a parallel ridge pattern of melanoma on the dermoscopy on the sole of the patient in figure 1. And in figure 2, you can see a mass on the patient's right big toe. If you suspect melanoma, do a 2 mm excisional biopsy, and if it is confirmed, it will need a wide local excision. However, if it is absolutely necessary in certain areas where you are not able to perform an excisional biopsy confidently, you can do a incisional or punch biopsy if this is needed, as there is no risk of metastasis, and this has been proven in a paper. Sentinel lymph node biopsy is needed in patients with T1B and above tumors. So this is the T&M staging based on the AJCC 8th edition. And you can see here, it ranges from melanoma in situ to T4B, depending on the thickness as well as ulceration status. Patients with T1B and above will require sentinel lymph node biopsy. And further to explain your T&M staging and the different pathological stage groups. Management of melanoma, surgical excision. Most micrographic surgery is only useful for lentigo maligna or melanoma in situ mostly. In patients with suspicious lymph nodes, they need a FNA or open biopsy. For patients with lymph node metastasis, you need to perform a radical lymph node dissection. Other options are chemotherapy, interferon alpha 2B, GM-CSF, target therapy, as well as immunotherapy. These are the surgical margins recommended depending on the tumor thickness. For in situ, 0.5 to 1 cm, patients with 1 or less millimeter in terms of tumor thickness, 1 centimeter, 1 to 2 millimeters corresponds to 1 to 2 centimeters, patients 2 to 4 millimeters, 2 centimeters, and more than 4 millimeters, 2 centimeters as well. Targeted therapy for melanoma. There are 3 categories. BRAF inhibitors such as vemurafenib, dabrafenib, and encorafenib. MEK inhibitors such as trametinib, cobimetinib, and binimetinib. c-KIT inhibitors such as imatinib and nilotinib. Immunotherapy for melanoma. Immune checkpoint inhibitors include PD-1 inhibitors such as pembrolizumab or nivolumab, PD-L1 inhibitor atezolizumab, CTLA-4 inhibitor ipilimumab, LAG3 inhibitor relatlimab, as well as other options like interleukin-2, T-VEC, which is an oncolytic virus therapy, BCG vaccine, or imiquimod cream. Always remember to advise patients at risk of skin cancer for sun protection. Seek shade and avoid sun exposure between 10 a.m. to 4 p.m. Wear a wide brim hat, wear sunglasses, use sunscreen, and tell them to use a broad spectrum SPF 30 and above. Apply 15 minutes before going out into the sun. In our tropical climate with strong sun, you need to reapply every 2 hours if you're still outdoors, as well as wear protective clothing. So the take-home message is to identify varied presentation of the different types of skin cancer, identify population at risk, manage the skin cancers, and remember sun protection. And with that, I thank you, and I hope you enjoyed Derm School. Have a fantastic time ahead.